Hi, everyone. Welcome to the Debate Your Colleague session. Today's debate topic is Hipec in ovarian cancer, ready for prime time. I'm Dr. Keiji Fujiwara from Saitama Medical University in Japan, and I will be moderating this great debate. Today, we have Dr. Wimian van Driel from the Netherlands Cancer Institute and Dr. Christian Marth from Innsbruck Medical University in Austria. Dr. van Driel will have 50 minutes to present the pro-argument for hypothermic intraperitoneal chemotherapy, which is Hipec. And then Dr. Marth will then have 50 minutes to present the con side of Hipec. After those debates, we will open up for the questions and discussions. So let's get started. Dr. van Driel, I'll start your clock. Please proceed.
Well, thank you. I'll first share my screen and start my presentation. Just to make sure that everybody can see my slides. Well, first of all, thank you very much for inviting me to defend the pro argument for the Hipec in ovarian carcinoma. I have no disclosures, and the next 15 minutes we will debate. This hour we will debate the effect of the place of Hipec in the treatment of patients with advanced ovarian carcinoma. Following our publication in 2018, although Hipec has a long-standing history in treating patients with peritoneal disease, the discussion on using Hipec in ovarian carcinoma was brought on a next level. And before I want to go into detail on the results of the study and the place Hipec should have, I will discuss these items during our presentation, the rationale for Hipec and Hipec during the several time points in the disease, and a little bit on the implementation. So I think it's good to realize, or to realize that there are similarities but also differences between Hipec and adjuvant IP chemotherapy. The similarities are it's an intraperitoneal administration of chemotherapy, and it increases survival when given the right drug in the right dose. But there are for sure there are differences as well. The Hipec is a single administration. It's under hyperthermic circumstances. Our study showed that there's no increase in morbidity and it's well tolerated. Since it's at the end, applied at the end of the surgical procedure, it's not limited by any adhesions, and heat induces impairment of the BRCA2 protein function, but it also increases the exposure to cisplatin. So the design of the OVPEC-1 study is depicted here, and I'm sure you're all familiar with it. Patients who had too much disease on board to undergo a primary cytoreductive surgery received neoadjuvant chemotherapy, followed by surgery, and during the surgery, patients were randomized between Hipec and no Hipec. Following that, there were 3 additional cycles given, and during the follow-up, patients had a strict program for their checkups. These are the basic characteristics. From the surgical point of view, there is no difference in complete cytoreductions or optimal cytoreductions. There was a difference in theater time, which is explained by the Hipec procedure, and as per protocol, patients had to stay 1 day at least in the ICU. The number of bowel resection was the same, as were the quality of life and adverse events. And important for quality of care, the time to restart chemotherapy was also the same in both groups. So if you look in more detail in the bowel resection, if you look at the whole group, there was no difference between the number of patients who underwent bowel resection. But if you look into the group who had bowel resections, there were more patients receiving a stoma than in the control arm. We don't know why that is. Maybe it could be that it was the preference of the surgeon, but this is something which needs to be discussed with the patient in the shared decision process. These are the curves for recurrence-free survival and overall survival, showing that there's an increase of 10% in overall survival after 5 years. So following the publication, there were a number of critical papers published by the same authors in various order. And here are the issues which were raised. And in the next 5 or 10 minutes, I will discuss a number of these issues. The fact that a surgical study, we know that a surgical study is difficult to complete. It took a long time, 10 years. It was stated that that's a surrogate marker for a strong selection bias. If you compare the desktop, for instance, which is a great study with great results, but if you compare the numbers there with the Ovipec 1, then I don't think the Ovipec 1 is really an exception. And as far as we know, there's no association between duration of the study and the quality of the trial, nor is there any association between duration and a strong selection bias. Regarding the study and the design of the study and the endpoints, in 2007, we chose the recurrence-free survival as primary endpoint because we just had the third ovarian cancer consensus meeting, which stated that PFS should be the primary endpoint for trials on ovarian carcinoma. And although it's a small study, and if it would have been negative, then it may have lacked the power to detect an overall survival difference. But since we observed a clear overall survival benefit, this argument doesn't hold. Regarding the length of the survival in control arm, I think it's good to realize if you compare it to other studies comparing or randomizing patients in either primary debulking or interval debulking, that randomization took place in those studies before start of any treatment. In the Ovipec 1 study, randomization took place during surgery, which meant that patients already had 11 weeks of treatment before the surgery. So if you really want to compare that, then you should add those weeks to the survival time. And then there's, as you can see here, there's not really a difference compared to other trials. Then the imbalance between RFS and OS. If you look at the hazard ratios, which is 0.66 and 0.67, and if you look at the length of the control arm, then if you add 1/3, then naturally you will get, if the control arm is 10.7 months, then 1/3 is 3 months extra. But if your control arm is almost 34 months, then the difference will be almost 12 months. So that's logic, right? That's not strange. Then regarding the histology, people say that there's an imbalance. Well, if you look at the numbers, then there's an imbalance or a difference of 3 patients, and that's not something that I would call an imbalance. And if you look at the forest plot, then for both the high-grade serous, but also for the other types, the benefit of Hipec was shown. So regarding the BRCA status, during the trial, we didn't have the BRCA status available because that was not routine to test it during the period the trial ran. But in the last year, we collected all the information on the germline, but also on the somatic BRCA mutation. As you can see here, there's, as you would expect with a randomized trial, there's no difference in presence of the BRCA mutated or the wild type patients with a wild type BRCA. So that doesn't explain the difference in survival. Of course, it's an open label design, but during the time the study ran in the Netherlands, the care for patients with ovarian carcinoma was more and more centralized. So surgery was performed by the same expert teams with a good collaboration with the GI surgeons, and patients either in the study or outside the study were treated accordingly. And I think all open labels have a chance on bias. But as far as we know, and as I know, the teams who performed and who collaborated didn't have the tendency to be biased. Regarding toxicity, we use the CTC adverse event scale. For surgical trials, Clavin-Dindo is often used, but Aliami published a couple of years ago a study where they compared the Clavin-Dindo with the CTC classification. And as you can see here, on the right side, the Clavin-Dindo classification underscored for 50% the number of toxicities. So I don't think we underscored the toxicity. I think we scored it as it was. Well, we've published the details on the results of the quality of life and the costs. Over here you can see the summary score and the scores for neuropathy and the abdominal symptoms, which are all equal for both groups. And if you look at the costs, there's a difference of which is acceptable for 15,000 euro, and it's acceptable definitely if you compare it to 1 year of bevacizumab or 1 year of PARP inhibition. So then there's always the argument on the other trial, the Korean trial. The Korean trial was published or presented, but I think it's good to realize that study was performed in a completely different group, mainly patients with stage 3 and 4 disease. The number was smaller, and patients underwent either primary debulking or interval debulking. So it was a very heterogeneous group. The cisplatin used was lower, and for the patients who received neoadjuvant chemotherapy, there was a tendency that it was a survival difference present. But I think if you really want to compare it, we have to wait for the final publication. So the next argument, which is I think rather bizarre, is that Hipec doesn't work for colorectal carcinoma. The Prodigy 7 was a study presented by the French in 2018 at ESCO. The final publication is not present yet, but you can see here that there's no difference in the both arms, have patients who received Hipec or non-Hipec. But it's good to realize that colon carcinoma is a completely different disease than ovarian carcinoma. And to compare the PARP inhibition, we have spectacular results in the ovarian carcinoma, which is great. For colon carcinoma, PARP inhibition doesn't work. But it doesn't mean that we don't give PARP inhibition to patients with ovarian carcinoma. It's comparing apple to oranges if you extrapolate the results of the Hipec study in colon carcinoma to the treatment in ovarian carcinoma. So the Dutch view on Ovipec following the Ovipec 1 study is depicted here in the PDCA cycle. So we adjusted the baseline evidence-based guideline. We received financial approval by the health authorities, which means that the insurance company will pay for the treatment, and there are 10 accredited centers who all have experience in Hipec. We received funding for the implementation of the Hipec, and we ensured that there is nationwide coverage. And at the moment, we are monitoring the results in the clinical audit, which is in place since 2014. And once the results are ready, we will act accordingly. So the next phase for patients where Hipec is sometimes applied is for patients with recurrent disease. And there are currently 2 studies. One is the Hipec study in France, which is depicted here. That's a study which is still going on. I think they need another 12 patients before the study is completed. But the design is shown here. So the patients with the first relapse more than 6 months from their last treatment receive 6 cycles of carboplatin-based therapy. Following that, after inclusion, patients are randomized between surgery or surgery plus Hipec, and the Hipec is performed with 75 milligrams per square meter. The primary endpoint is overall survival, so it will probably take another 2 years before we've got results. And the next study on recurrent carcinoma is the phase 2 study presented by Oliver Zivanovic at ESPO this year, where 98 patients with a platinum-sensitive recurrent ovarian carcinoma are randomized during surgery between surgery plus or minus Hipec, and the Hipec is performed with carboplatin. Following the surgery, the control arm received 6 cycles of chemotherapy, and the Hipec arm received 5 cycles of chemotherapy. And there was no maintenance treatment permitted. So if you look at the results of this study, the groups were balanced for the basic characteristics. And on the right side, you can see the bar graph for the complete cytoreduction, The control arm had a slightly more percentage of complete cytoreduction, and we know from the desktop study that that's an important feature. And the number of bowel resection was more in the control arm compared to the Hipec arm. If, however, you look at the survival curves, then it's clearly visible that there's no difference in survival. I suspect that my opponent, although we look at the same picture, will draw this conclusion, that Hipec doesn't work for recurrent ovarian carcinoma, whereas I think that a more scientific conclusion should be that Hipec with carboplatin seems not effective for recurrent ovarian carcinoma. So the last status for patients with ovarian carcinoma, where Hipec is sometimes applied, is during primary debulking surgery. And for that reason, to get an answer on that, the OVIPEC-2 study is initiated. Patients with stage 3 ovarian carcinoma are during surgery randomized between no Hipec or with Hipec, and following that 6 cycles of chemotherapy are given, and maintenance therapy is allowed per investigator discretion. So the randomization takes place after the surgical procedure, and so far 10 patients have been randomized. The study is open since January 2020. But due to COVID pandemic, it was discontinued since March till July, and reopened in the Netherlands since July. So, of course, we did learn from the OVIPEC-1. For one, regarding the trial organization, we obtained adequate funding for the Hipec procedures for centers in the Netherlands. We also received funding for trial management and PhD students. And we installed an international steering committee, and we thought, collaborate with the 3 GCIG and ENGOT. Regarding the design and following the discussions within the international steering committee and with the GCIG and ENGOT, we changed the randomization is at the end of the cytoreductive procedure. There's a stratification factor for the result of the CRS, near complete versus complete. Everybody takes pictures at the end of the CRS to check for completeness of the surgery, and we report the complications, or we register the complication both in CTC adverse event and the closing window. And the Hipec can be performed by an open or closed technique. So in conclusion, for the primary CRS, we've got the OVIPEC-2 study, which will give us an answer whether Hipec is beneficial for this group of patients. For the interval CRS, Hipec improves RFS and OS if you use the cisplatin 100 milligrams per square meter, and it's incorporated in the Dutch guidelines, in the NCCN guidelines, and in the Ontario Cancer Care Network. And for recurrent disease, carboplatin doesn't seem to work, and we have to wait for the SHIPOR study in France to get an answer whether that approach might work. So I think it's, if you look at over time, then we have small steps and bigger steps in which way we improve the outcome for patients with advanced ovarian carcinoma. We can only do that through collaboration with a lot of people, which are shown here in this graph. And I'm especially grateful for all the participation with the international groups who are working very hard to start up the OVIPEC-2 in their own country. And with that, I would like to conclude, and thank you for your attention.
Okay, thank you, Dr. Van Driel. The next speaker will be Dr. Moth. Please begin your presentation of the Con's stance on the Hipec in ovarian cancer, please.
Yeah, first of all, I would like to thank for invitation to this outstanding debate, and I would like to congratulate Dr. Van Driel for this very important trial which has been performed, and I think will stimulate the development in ovarian cancer treatment for years. These are my disclosures, but none is important for this debate. And This slide shows how was the development in the median overall survival in phase 2 trials over the years. And what you can see, yeah.
We cannot see your slides yet.
Okay, I tried to, sorry for that. I already shared. Do you see it now?
Not quite yet.
You are sharing the screen, it's telling me.
I can see my face here.
And now? No?
It's getting better. Choose the slideshow.
Do you see the slides now?
Yes.
Yes, so I'm sorry. So as I said, first of all, I have to congratulate Dr. Van Driel for this very important trial. And these are my disclosures, and none of them is important for this presentation. So what we understand is that when we look on the overall survival in phase 2 trials in ovarian cancer, that there is not such a major impact over the recent years. And there is, of course, an urgent need to improve overall survival. And we are now confronted with a new possibility with Hipec therapy. So what are the principles of Hipec? So we have 3 parts. First of all is the IP part, intraperitoneal therapy. So we can say we have some kind of an onion theory. So we have the tumor nodules, we bring them to a chemotherapy, and the high drug level has a direct exposure to the tumor nodules and penetrates into the tumor, although we know it's only for a few millimeters. And what we expect is that some of the chemotherapeutic agents is also going by microcirculation to the tumor. And indeed, these are all data from Howell telling us that you can see that the plasma levels are very similar for IV and IP cisplatin, but obviously the IP value of the peritoneal fluid is higher. So therefore, we hope that IP therapy will improve the overall survival in ovarian cancer. And indeed, there have been 3 IP trials, and all of them were positive. So we were very optimistic, and in 2007 we organized a consensus conference, and we at that time recommended IP therapy should be proposed to all ovarian cancer patients. However, we had to recognize that this IP therapy was heavily imbalanced, and many factors were different, especially in the GOG 172 trials, with a higher drug, different dose intensity, the not right comparator, and so on. So in the end, we can say we compared apples with pears, and the final conclusive trial was the GOG 252, in which IV carboplatin was compared to IP carboplatin with the same amount of IV paclitaxel and bevacizumab in both arms. And this was also compared to the old Armstrong regimen with bevacizumab. And as you know, these were the results presented. So compared with the IV carboplatin reference arm, neither the duration of PFS or overall survival was significantly increased with either EP regimen. And on the other hand, IV regimen was better tolerated than IP cisplatin. So therefore, it's no surprise that the ESMO-ESCO consensus conference concluded that IP therapy is not a standard of care for first-line therapy. So this, of course, obviously is negative. So the next point is heat. Can we use heat to improve the therapeutic efficacy? And indeed, there are some hypotheses that heat might improve the penetration of the cytotoxic drug, increase the intracellular accumulation, amplify the cytotoxic effect, induce apoptosis, activates heat shock proteins, inhibits angiogenesis, denaturize proteins, overcome chemoresistance, and modulate immune response. So this is very interesting factors which might have an impact on the treatment, but these are interesting hypotheses, and the evidence for clinical relevance is very weak. So here we can pose a question mark. And the third principle of Hipec is a single-shot therapy. And what is the evidence for single-shot therapy in ovarian cancer? So there is one major important trial in epithelial ovarian cancer randomizing standard dose platinum chemotherapy IV or multiply high-dose chemotherapy. And the results are very clear. So there is no benefit by giving a single shot or high-dose chemotherapy to ovarian cancer compared to conventional dose therapy. And when we look at what is really the evidence for one-shot high-dose chemotherapy in ovarian cancer, this is the list of the randomized trials. And you can see there are not so many telling us this answer. So again, here we have a negative result. As already has been alluded by Dr. Van Driel, what is the activity in Hipec in colorectal cancer? I think many of the trials in ovarian cancer were coming from the experience of Sugar Baker and later, telling us that Hipec is working so good in colorectal cancer. This trial has also been presented and showing that the addition of Hipec on the top of cytoreductive surgery did not influence overall survival and recurrence-free survival. And this is also confirmed for other approaches, prophylactic Hipec to develop peritoneal carcinomatosis or adjuvant Hipec. None of these trials succeeded in meeting the primary endpoint. So although we always hear that Hipec is working so well in colorectal cancer, this is not true. So there is actually at the moment no evidence that this can be recommended. And what is now the evidence for activity in ovarian cancer? I think we have to go back to the first randomized trials, which said that this is a phase 3 trial, although it included only 120 patients to Hipec and no Hipec, with a significant improvement of overall survival. This trial has been heavily discussed, and it was found that there was a lot of problems, no description of statistical analysis, no definition of endpoints. They included, they reported the mean survival after 8 years, and nobody knew what patients have been included. 2 external reviewers already showed that there was no difference in hazard ratio and not info at all on platinum-free interval. So we can say that there's a real negative trial. Another trial from France did not come to an end because it was closed prematurely due to complications. So there is a list of many trials which either didn't report positive results or were concluded prematurely. And also this trial has already been mentioned by Van Driel, telling us the Korean trial by Limenthal, which has only presented as an abstract at ASCO 3 years ago. And in this, patient in stage 3 and 4 were treated either with Hipec or in the standard control arm. And what we can see is that there's no difference in progression-free survival, no difference in the overall survival. So I think, again, unfortunately, a negative result. And this is now the well-mentioned Hipec trial presented and published 2 years ago in the New England Journal of Medicine, and showing a marked increase of 3.5 months in progression-free survival and 11.8 months in the overall survival. So on one point, I think we have to mention that 10.7 months is really some of the worst progression-free survivors reported ever. So this might be caused by a negative selection of patients. And the second point, of course, it's obvious that we have a modest improvement in progression-free survival, but a marked improvement in overall survival. So, and this to explain this difference is very difficult. And Spriggs and Jivanovic wrote in their editorial about this manuscript that, of course, we have to mention that both PFS and overall survival is very short in the reported trial. And during the trial, the sample size planning has to adapt because of the difference of the observed PFS. So it was reduced from 18 months to 10.7 and from 27 months to 14 months. So the most important factor, I think, it's also that there is a much improvement in overall survival, much larger than the progression-free survival difference. So the only explanation for such a difference could be later treatment difference. So which has nothing to do, obviously, with the Hipec treatment. So I think that is something we should analyze more deeply. It is clear that those patients in the Hipec got more chemotherapy, and the early intraoperative administration of IP therapy versus routine postoperative chemotherapy has also to be mentioned. Would be therefore better to compare Hipec versus IP to understand whether indeed the Hipec approach is what is important. And this trial, only neoadjuvant chemotherapy patients with the interventional debulking have been analyzed. So from that point of view, of course, this is for many of us not the standard of care in the treatment of ovarian cancer, and we have to await the Hipec trial number 2. So in conclusion, they told that it's a very important first step, but should not drive changes in praxis yet. And of course, there is some points we have to mention. There is a heterogeneity of the results between the various study centers. So the impact of Hipec in the Vandril trial was lowest in the most actively recruiting center. And the small center had a greater impact. It is unclear how were patients selected. So it was defined not suitable for primary debulking, but the criteria have not been defined. And what we have learned also recently, Vandril mentioned the desktop 3 trial, how important it is to define criteria for inclusion into a clinical trial, because otherwise you might lose this very important factor. The selection of site and surgeons was also not defined. So the qualification criteria was to have a machine available to do Hipec. And I think in ovarian cancer, this might not be really enough to do and perform such a high quality trial. And one important factor is that the surgeon knew before operation if the patient will receive Hipec. And this, of course, could bias the surgeon by doing the procedure. A long recruitment period and the lack of information on quality of participating center has been mentioned. We understand that toxicity is underestimated. I will show later an example. The higher rate of stoma rate was also mentioned. We really don't understand what is the reason for this. And there are some statistical remarks which, of course, impair and might affect the explanation for the results. When we look here at the difference in toxicity, it's really how was the toxicity collected. I would like to mention alopecia. In the non-Hipec arm, only 16% of patients had alopecia by getting carboplatin paclitaxel. So we know that almost all will have an alopecia. So there is obviously a problem in the collection of the data in this trial. And you see that in the majority of side effects, there was an increased toxicity, and due to the low numbers, many of them might not be significant, but the absolute numbers count at this low frequency is important. And of course, once again, this increase of stoma rate, which also is important. So when we look on what do we see nowadays with all the trials, the reported phase 3 Hipec trial do not improve very much in the overall survival compared to the other trials which have been performed over the years. So it is an interesting approach, but it's not a major step forward, unfortunately. And when we look on how many ongoing trials on Hipec are reported in clinicaltrials.gov, we understand that this is not standard chemotherapy, not ready for the prime use, but Hipec is far away from being established. At the moment, more open questions than answers. So coming to conclusion, I can say that there are no adequate randomized data establishing Hipec as the standard of care for relapsed ovarian cancer. That is obvious. Almost all are negative. Data about Hipec for first-line ovarian cancer are not convincing so far and do not change the standard of care, so which still remains in our hands, debulking surgery and IV chemotherapy for all patients with ovarian cancer. Surgical survival improvement has been prospectively demonstrated only in one IDS interventional debulking situation and in one single trial, and I think this definitely needs to be confirmed before we can adopt this as our in clinical praxis. There is a significant toxicity with Hipec, and many trials have been closed for toxicity, and further use of Hipec should be limited for that reason to prospective trials, and these trials should be large enough and should avoid the bias, for example, randomizing patient to Hipec or heated saline in a double-blind manner and assigning the arms at the very moment of the completion of surgery and not before, as I heard from the EU trial. And so with this hot water from Iceland, I thank you very much for your attention.
Okay, thank you, Dr. Moth, for your great presentation. So before we open the question and the answer from the audience, I'd like to have some comments from Dr. Van Driel to Dr. Moth's presentation. Do you have any comments?
Yes, well, thank you very much. Thank you, Christian, for an excellent presentation. Of course, I do have some comments. I think there is one study, the OVPEC-1 study, which showed benefit, and your remark that it should be confirmed. I think given the difficulty completing the first study, it will be very difficult repeating the OVPEC-1 study, definitely given the result that it's effective. So I don't think patients will be willing to be randomized in a study during interval cytoreductive surgery where they have a 50% chance of not getting the Hipec. But I think that's, from an ethical point of view, that I think that will be difficult. And as I said in my presentation, the Korean study is very heterogeneous. So I don't think we can extrapolate those data to and compare those data to the OVPEC-1 study. The study DOG 252, where the combination of bevacizumab and cisplatin was used, they didn't use the Armstrong schedule. They used a lower dose of cisplatin, 75 milligrams instead of 100 milligrams. And if you look at all the IV-IP studies, then the only one who are positive use cisplatin 100 milligrams per square meter. So I think there's definitely something with the dose. Probably the combination with IP cisplatin 75 milligrams and bevacizumab doesn't work. And I think that should be the conclusion. And again, I think it's very difficult to extrapolate the results of the IV-IP adjuvant studies to the Hipec, because it's a different treatment. They have the same base, but it's a different. They have different aspects. Regarding the differences in the recurrent or in treatment of recurrent disease, we did check for that in the OVPEC-1 study, and we didn't observe any difference in the treatment between recurrent disease in the control arm compared to the Hipec arm. So I don't think that explains the difference in overall survival. And regarding the selection of the centers who participated in OVPEC-1, there were 6 centers. They were all Hipec centers. And Hipec centers means that they all have extensive experience with performing Hipec for colon carcinoma. And the gynae oncologists who participated in the study have all had a very close collaboration. They formed one surgical team with the GI surgeons. So the gynae oncologist learned the Hipec from the GI surgeons, and the GI surgeons participated in the surgical procedures. I think those were the main. Regarding one aspect, the long duration of the study, it's definitely a very long time. 10 years is almost too long, because a lot of things happen during those 10 years in further treatment. But the hurdles were mainly financial and also logistic, which is something we covered now in the OVIPEC-2 study, because we got the funding for the Hipec treatment, and we got the commitment of both the boards of the hospitals and the insurance companies. So hopefully that will take away the financial and the logistic hurdles. So hopefully we can complete this OVIPEC-2 in 5 years. I think those were my comments.
Okay, thank you. Christian, you have any comment back to Virginie?
No, I think I gave my arguments, and for sure, I think I don't mean with validation that you should repeat. Somebody should repeat OVIPEC-1. I think OVIPEC-2 is a very good trial, and this could really confirm what is the role of Hipec in ovarian cancer. I think that is what we really need. If OVIPEC-2 is positive, I think that would convince me that I would change my first line treatment in ovarian cancer.
That's a great comment. Thank you, Christian.
Thank
okay,
you.
well, we have one question from the audience for Dr. Van Driel. Okay, so do you have data on further therapy down the line for these patients?
Yeah, we did register the treatment, whether patients received chemotherapy or other maintenance therapy or surgery. So we do have that information, and there's no difference between the two arms.
Okay. So another question is, what do you think of the statement that better survival is attributed to complete site reduction and not to Hipec?
Well, if you look at both arms, then the results of the site reduction is comparable in both arms. So in both arms, the same percentage received complete site reduction or optimal site reduction. So that doesn't explain the difference in survival.
Okay, very good. So another question is to both the speakers. Okay, so the world was quick to accept a randomized control trial on cervix cancer, such as a LAC trial, but don't want to accept a randomized trial on Hipec. Why? So this is the question. Do you have any comment, Christian?
Yeah, I think we cannot compare this with one with the other. So I think the LAC trial has been in the meantime confirmed by a lot of retrospective data, and it's not a single case. We understand now, and that's a completely different situation. The OVIPEC trial is one positive trial out in between many, we could say, negative trials or not very enthusiastic trials confirming it. So I think it's very interesting. We should continue to elaborate on this, but we cannot adopt this as standard of care in treatment.
Thank you. Dr. Van Driel, any comments?
Well, yeah, I think it's the LAC trial is a different. I think there were many more centers who participated in the LAC trial, and it was really a huge change in treatment. I I think centers were really adjusted to the minimal invasive treatments, and they suddenly heard, well, we shouldn't do that. So that was really had a big impact on their. So that's why I think it's more controversial. And in that respect, the OVPEC 1 is I think is different. It's maybe easier to accept.
So the next question is for Van Driel. How important was the fact of randomization before surgery?
Well, randomization didn't take place before surgery. It was taking place during surgery. So what happened is that when you start the surgery, you analyze the abdomen, you make a surgical plan, and once you anticipate that you can achieve a complete site reduction or optimal site reduction, then the patients were randomized. I think you can argue both ways. Either you think, well, the Hipec works, so I don't need to perform a huge resection because the Hipec does the rest. Or you say, well, this patient didn't randomize for Hipec, so we should really perform a major surgery to get a complete site reduction. I think you can argue both ways. And I think in reality, the surgical teams who participated in this study and their goal was to get a maximum surgical effort, to perform a maximum surgical effort, no matter what the outcome of the randomization was. We know that because we took part of the study, but I think for the OVPEC 2, in order to convince the others, those who don't participate, that's the reason why we changed this, and now we perform the randomization at the end of the surgical procedure.
I think that's a very important factor because this could also be one explanation about the higher stoma rate, because as a surgeon, knowing that the patient will get a Hipec fears more as an insufficiency of the bowel resection and doing a stoma. So I think there is obvious a surgeon knowing that the patient will get Hipec will adapt the surgical procedure, and this is for sure a bias which we should avoid.
Okay, very good. So the next question is for both of you. So, can you comment on the recent JAMA paper with the differences in OS in the primary surgery, which is primary site reductive surgery, and Hipec versus primary surgery only, which is 16 weeks differences. Van Driel?
I must confess, I haven't seen the paper yet, so it will be difficult for me to comment on that. I'm not sure. Was it a randomized how many patients were randomized?
It's a retrospective study in the JAMA network.
Ah, okay, yeah. Well, yeah. I think the problem with retrospective studies, and especially in the Hipec world, that will be very difficult to be sure that it's comparable groups. And I think the bias could very well be an important factor in that. So although it may be promising results, I don't think it will change the standard of care. And so we definitely need a prospective trial.
Right.
Yeah, I completely agree. So we had already discussed that there's a problem if a surgeon knows during surgery whether the patient will get Hipec, and in a retrospective, of course, it's so heterogeneous that this cannot be used for any relevant conclusions we can draw.
Mm-hmm. Yeah. So everyone can all agree that the prospective randomized trial is much more important. Okay. Then another question came in. So for Dr. Van Driel, any comments on the different chemo regimen for the Hipec?
Well, that's a good question. I think we chose cisplatinum because we started our trial just after the results came out of the Armstrong study, where they used cisplatinum 100 milligrams per square meter, and we had experience in our center with Hipec and cisplatinum. When you choose your drug, you have to know what the effect of heat is on the drug. And we know from Taxol, for instance, that the window that the temperature is really beneficial is very small. So if the heat is too high, then Taxol is working less. So that's why I think Taxol is not the best drug to use. And another important fact is the penetration, I think the carboplatin is penetrating less than cisplatinum. So for that reason, I would favor the cisplatinum.
Oh, okay. All right. So.
But that also, to add to that, that also makes it very difficult to give an answer on the result of Hipec, because there are, especially if you look at the retrospective studies, there are so many different drugs given that it's impossible to draw any conclusions from that.
Yeah, that's right. Okay, so any comments on the adding the adriamycin? One of the audience asked.
Yeah, well, I think that's I think it's the same answer as we really have to know what the effect of heat is on adriamycin before we can really use it. Yeah, and know how it penetrates the peritoneum. Yeah, that's.
Yeah. Okay.
Adriamycin was associated with a heavy toxicity by IP protocols and completely abandoned. So I think that's not a good drug to think about in combining it with heat too. So adriamycin, I would be very cautious. Yeah.
Yeah, Christian, I totally agree. You know the old time, the IP, the studies experience. Okay, another question is the question is for both of you. Do you think that the trial should be done again in the modern age?
Well, I think if you want to repeat the Ovipec 1, then I could think of a design that you perform Hipec with or without cisplatin. Just to find out whether the heat is important or whether the combination is important. But I think you can find that out in lab tests as well. You don't need to perform a clinical trial for that. You can perform, in our center, we are setting up a program where you can perform Hipec in mice. And that's a situation where you can look into those mechanisms.
Right. Christian?
Yeah, I think that's a very good question, because we know now much more about ovarian cancer biology. So, of course, one could speculate that increased dose activity might play a major role in BRCA mutated or HRD positive tumors. So that could be a reason to select patients for such a trial in a different way. And of course, I think we have also to think about the approaches. What is the role of bevacizumab and what is the role of PARP inhibitors nowadays? And we have to include in a modern protocol carboplatin and paclitaxel, and a little bit of cisplatin IP or Hipec is not a good approach, which might have a future for the treatment of those patients.
Okay. Very good. I think the audience who asked this question added, is it worthwhile? So probably he or she may want to test the Ovipec once that is reproducible or not. So that's the probably the reason why he questioned. So since we have no more question from the audience, so I'd like to ask from myself to Dr. Van Driel. So as you mentioned that it is important for you to compare if the heat, the effect of the heat is important, or IP cisplatin was important. So did you or are you testing that hypothesis in the new trial now?
Well, no, not on this trial. No. On the Ovipec 2, patients get either the surgery alone or the surgery with Hipec. But we are working in the lab to make organoids and to test that. That's the plan, to test it with heat only or heat with cisplatin, or that's the whole idea of getting more insight on how the Hipec is effective.
Okay. So the reason why I'm asking this is that everybody they say no for the IP chemotherapy now, but if you look at the randomized phase 2 trial, OV21 from the Canada, the IP group showed the better their response, the progression-free rate. So there may be some rooms for the IP chemotherapy itself. So I think it's very important to test the effect of heat is good enough to enhance the chemotherapeutic agent. So I really endorse that the idea should be tested in the future trial. So, are there any comments, Christian, for this?
No, I think that this was my last sentence in the presentation. That I think a randomization into groups, one heat alone or heat together with chemotherapy. That I think that would be very important. I have one question to Willeman. You already have now the data about the BRCA mutation in your patients. Do you have any evidence that there is a difference in response and outcome by Hipec versus no Hipec, according to the wild type or mutated phenotype?
Yeah, we just received these results of the BRCA testing, so we are analyzing that now, and we will definitely, once we know it, we will definitely show it. But that's work in progress. Yeah, we're definitely looking at it.
Yeah. That's very important question. Very important question. Everybody wants to ask. Actually, the question asked from one of the audience too. So we are very much looking forward to the further, collaboration, probably international collaboration trials to clarify the true benefits of the hypothermia and intraperitoneal chemotherapy for the very difficult ovarian cancer patients. So I think that we have left only 1.5 minutes. So I'd like to close the session by saying thank you, both of you. That is all time. If you have any, I'd like to mention that to the audience that if you have any further questions for Dr. Van Driel or Dr. Marth or to me, please contact us through the IGCS link chat feature here in the meeting portal. And once again, I'd like to thank you, both of you, and thank all the audience